Hello everyone. Today I'm going to present to you guys a presentation that I prepared. This is actually a second take, as I just after recording realized that my microphone wasn't being picked up by the recording. So this is a second take. I hope I hope it's even better than the first one. So we're going to look at this article, which was published in the New England or Journal of Medicine, Ketamine versus ECT for non-psychotic treatment-resistant major depression. So this was published quite recently, just a month ago, in the New England Journal of Medicine. So what is this article all about? The title speaks for itself, but there are some things that I think we should discuss. So what we're going to do is do an analysis of the statistical hypothesis testing and what are our objectives. To quickly summarize the paper and then to analyze the statistical hypothesis tests used and their appropriateness. We're going to be focusing mainly on the primary outcome because they're estimated to suffer from depression, and the effectiveness of antidepressants, that is to say the pharmacotherapy, is suboptimal in almost a third of the patients. So ketamine and electroconvulsive therapy are two options for the management of treatment-resistant depression, and we are going to see if ketamine is non-inferior to electroconvulsive therapy. Of course, that antidepressants are not the only possible therapy for depression. There are many other things that we can employ, such as lifestyle changes, such as cognitive behavioral therapy. But this is the first line of pharmacotherapy, and in many patients this is insufficient. So we need to look at options for these patients as well. So how was this trial structured? It was designed as an open label because it's really hard to blind ECT, randomized, non-inferiority, multi-center trial. Non-inferiority is something that we need to consider with a lot of care when we are going to analyze the statistical testing that is going to be employed in this paper. So keep that in mind. And okay, what are the inclusion criteria? They included 403 patients, all of them adults, that were diagnosed with major depression without psychosis, that previously underwent at least 2 trials with antidepressants, and that were not adequately treated. They had objective measurements for all of these, okay, but we are not going to go into the detail that it's needed to determine what is a patient that is not adequately treated and what is the definition of 2 previous trials with antidepressants or the diagnosis of depression or anything like that. To keep on going with the characteristics of the trial, they underwent stratified randomization according to treatment center, which is almost standard when we are dealing with trials that are multi-center in nature. Patients were randomized to 2 groups, either ECT 3 times a week, which were 203 patients, or intravenous ketamine, which were 200 patients. The primary outcome was the percentage of patients who had a decrease of at least 50% compared to baseline in the score of the Quick Inventory of Depressive Symptomatology Self-Report, or the QIDS-SR-16. So this is our primary outcome, and this is what we are going to focus on to see if the analysis was appropriate or not. I believe this is the most interesting as well, as it will deal with aspects of non-inferiority trials and a test that we have not previously seen in our classes in PPCR. So this will be, I believe, most interesting. but other secondary outcomes were analyzed as well. Mainly, this is not an exhaustive list. There were other outcomes that were assessed as well that I did not include here, but the main secondary outcomes that were analyzed were the percentage of patients who had a decrease from baseline of at least 50% in the score of the clinician rated MADRS 21, which is another measurement of depressive symptoms in patients. Measures of remission according to the, again, QIDS-SR 16, i.e. a score of less than or equal to 5. So let's just talk a little bit about the primary outcome. So this right here, the quick inventory of depressive symptomatology self-report, can be interpreted as an ordinal or continuous variable by itself. But it's important to notice that the authors didn't take this by itself, the result of the questionnaire by itself. They transformed this result into a dichotomous variable, a categorical variable that has only two possible values, a success or a failure. If the patient had a decrease of at least 50% on their score compared to baseline, they had a success. If the patient did not have a decrease of at least 50%, let's say they decreased only by 10% or 20%, or let's say that it increased by a number, 10%, 20%, it doesn't matter. This patient is considered a failure for the primary outcome. So this is a dichotomous variable and by definition a categorical variable. Okay. The secondary outcomes, most of them are also dichotomous secondary categorical variables as well. So this one also categorical and dichotomous variable. This one as well. And this one as well. But the last one that I included was not. See that on this one they took scores at the end of treatment visit on the global self-evaluation of memory. This was considered as a continuous variable, and although we will not be going into detail on this, and I will not be showing the comparisons between groups for this measurement, it is important to realize that they probably included this to justify the reasoning of the non-inferiority trial. So ECT is a therapy that is very effective for treatment-resistant depression. This has been widely demonstrated in the literature before, but there are some issues with ECT, mainly relating to stigma of ECT and also with side effects of ECT. One of the most common side effects of ECT evaluation is something that might also be helpful to authors, that they are trying to show us that it is not unacceptably worse to prescribe intravenous ketamine in comparison to ECT when we're talking about patients that have non-psychotic treatment-resistant depression. So keep that in mind, and let's move forward. So the analysis of the statistical hypothesis testing. Definition of non-inferiority margin of minus 10 percentage points. So when we're talking about a non-inferiority trial, this is a very important step, the definition of the non-inferiority margin. And unfortunately, at least from what I could tell, reading the manuscript itself and the protocol, I could not find a description of calculus or a delve into the literature that justified the exact setting of minus 10 percentage points. Looking by myself into the literature, I could see that the effect size of ECT in this population can be effect size, but I did not see a justification, an explicit justification for the minus 10 percentage points inferiority margin that they set. Nevertheless, that's what they decided upon, And they analyzed the primary outcome, which we defined in the previous slide as the percentage of patients who had a decrease of at least 50% compared to baseline in the QIDS-SR16. They analyzed it using this test, the Farrington-Manning test. And what is this test all about, right? This is a test that it is appropriate to detect non-inferiority, and it takes as inputs the group 1 success rate, in this case the ketamine group, and the group 2 success rate, in this case the ECT group, the non-inferiority margin, which was defined as minus 10 percentage points, and the alpha, which was set as 0.025, because this is a test that is one-tailed only. So we are only looking at non-inferiority. We are not looking at superiority as well. So to define an alpha, they decided upon 0.025 to be compared, which is comparable to when we use an alpha of 0.05 in a two-tailed test. The null hypothesis in this test is that the difference between group 1 success rate and group 2 success rate is smaller than the margin. The margin is defined as a negative number. So what does this actually mean, right? This means that if you take, let's say, as an example, the group 2 success rate as 50%, and you have a margin which is defined as a negative number, let's say minus 10 percentage points. Okay, the difference between 1 and 2 is not in the null hypothesis, it is smaller than the margin. So to be smaller than minus 10, you need to be minus 11, minus 12, minus 13. If you take group 2 minus group 1, okay, let's say 50% minus, let's say 39%, this would be 11%. Okay, let me rephrase this. Group 1 minus group 2, 39 minus 50, this is minus 11%, right? So if you take minus 11% and compare it to the margin, it is smaller than the margin, and this is the null hypothesis. The null hypothesis is that group 1 is unacceptably worse than group 2 in simple terms. In more simple terms, the null states that group 1 is unacceptably worse than group 2. So this is a kind of backwards definition. It's hard to understand this at face value, the null hypothesis definition, but it's easier to say it in this way. The null states that the group 1 is unacceptably worse than group 2 if you take into consideration the margin that was set. Okay, but the mathematical definition is the difference between group 1 success minus group 2 success is smaller than the margin, and the margin is defined as a negative number. The alternative hypothesis is that the group 1 success rate is not smaller than the group 2 success rate plus the margin. So let's say that group 2 success rate is 50%, and you sum into that minus 10 percentage points, then it's 40%. So the alternative hypothesis is that the group 1 success rate is not smaller than 40%. In the example that group 2 success rate was defined as 50. Okay? So in this case, in the alternative hypothesis, the group 1 success rate can be smaller than the group 2 success rate, but it cannot be unacceptably worse. And the definition of unacceptably worse is in accordance to the margin that was defined. So the Farrington-Manning test then compares the rate difference of successes between two groups to a preset value. The preset value is the margin. As the outcome was defined as a percentage of responders, so we have a rate difference, right, of successes when we have a percentage of responders. This test is appropriate to be used. So what did they find, right? We will take into consideration what they found here on the left, and on the right we have an image which was taken from the textbook for the PPCR. It has a higher percentage of patients that responded in comparison to ECT. And then when the the Farrington-Manning test was conducted, the P was less than 0.001 for non-inferiority of ketamine in comparison to ECT. This is expected as ketamine was actually performing better in this trial than ECT. But remember, this trial was designed as a non-inferiority trial, not as a superiority trial, as we are most accustomed to see. So as the analysis is pre-specified, we cannot talk about superiority. So here, the second part of the image in the PPCR image for the textbook of PPCR, it talks about how to interpret the findings in a trial that can state superiority. This is not the case in our trial, as we pre-specify the analysis as a non-inferiority trial. So what we are seeing here is equivalent to what we are seeing here. So the control group, which is ECT, performed worse than what we are seeing in our intervention group. Okay, since we are talking about a trial which is a non-inferiority trial, we can say that ketamine was non-inferior to ECT. This would be the case as well if ketamine performed worse than ECT, but not unacceptably worse than ECT in accordance to the margin. So we would still say that it's non-inferior, okay, in this kind of trial. And why do we do these kinds of trials, right? Because ketamine has a different side effect profile, right? And if we have, so let's go further, right, to the conclusion. So the trial showed the non-inferiority of ketamine versus ECT in the treatment of the target population. If the trial had been proposed as a superiority trial, it might have shown superiority of ketamine, but there wasn't this pre-specified analysis. Okay, so we talked about that already, but why not do a superiority trial from the get-go, right? First of all, the literature didn't really support ketamine as being probably better than ECT. Previous findings show ketamine as performing worse than ECT. I believe that this is the first trial that shows ketamine as being performing better than ECT in this target population. Also, taking that into consideration, right, that ketamine might have performed worse than ECT, why consider it in this population? Because of the issues that arise with ECT that we touched upon before, right? So it might be that even if ketamine was slightly less effective than ECT, that it would still be a good option, that because patients might adhere more to ketamine trial, to ketamine intervention, patients might have less side effects. So it's still a good thing to see if it is not unacceptably worse than ECT in this population, so that clinicians can engage patients in shared decision making, taking into account both possibilities, right? ECT and ketamine as well, in the treatment of treatment-resistant depression that has no psychosis characteristics. And that's all I wanted to talk about. I hope this has been somewhat helpful, and I'll see you guys later.